Hello, this is Dr. Marty Lofka. I am the Internal Medicine Clerkship Director at SIU School of Medicine. And if you've made it this far, you've already met me in parts 1 and 2 of basic ECG interpretation. So as a review, in the first two parts of this workshop, we talked about the basic preliminary information about ECGs. We talked about how to determine rate. And in part 2, we extensively discussed about how to determine rhythm in a systematic fashion. So in this final portion of the workshop, we will talk about axis. We will talk about intervals and morphology in a little bit more detail. We'll talk about how to identify ischemia and infarction just briefly, and we'll also briefly talk about how to identify left ventricular hypertrophy and right ventricular hypertrophy on an ECG. So let's discuss axis first. So we determine axis from the limb leads on the ECG. So what is axis? Axis is the average direction or vector of the electrical activity of ventricular depolarization. And as I mentioned before, we only take a look at the limb leads in order to determine axis. We represent those leads on what's called an Einthoven's triangle, which you see in front of you. And so you can see where the positive and negative portion of each lead is associated with the placement of the electrodes. You can see that lead 1 runs from the right arm to the left arm, becomes more positive towards the left side of the patient. And that lead also runs at 0 degrees. Lead 2 becomes more positive as the electrical activity moves down towards the left limb. And that lead runs at 60 degrees. And you can see how lead 3 also becomes more positive as it's moving downward, and it runs at 120 degrees. And then the calculated leads are AVR, AVL, and AVF. And so AVF is at 90 degrees, AVL is running at -30, and AVR is running at -150. So if we're trying to determine what our axis is, we're going to look at the leads that are perpendicular to the leads at the angles that are of interest. So we know that normal axis is -30 to +90 degrees. And so I see that my AVL lead runs at -30, and the perpendicular lead to that is lead 2. So I know that lead 2 is of interest to me. And then the perpendicular lead for 90 degrees, which is lead 1. So my 90-degree lead is AVF, and the perpendicular lead to that would be lead 1 that's running at 0 degrees. That's my other lead of interest. And so I'm going to take a look at leads 1 and 2 in order to determine axis. So for lead 1, if that is positive and lead 2 is positive, I have a normal axis. And that means when the QRS complex amplitude is mostly positive, so it's above the baseline, there is more of the QRS complex that is above the baseline as opposed to below the baseline, then they are positive, then I have a normal axis. If lead 1 is positive and lead 2 is negative, I have a left axis deviation. And then if lead 1 is negative and lead 2 is positive, I have a right axis deviation. Many resources are going to teach you how to calculate axis from determining which lead is isoelectric. And that's a good skill to have, but certainly when we're taking a look at ECG when we're on the wards and quickly want to take a look at what's happening with our patient, it's a lot easier to just know if there's an axis deviation, whether it's right or left. And so a easy, quick and dirty mnemonic to use is to think about the rule of thumbs. And so we're going to quickly take a listen to a video where it talks about doing the rule of thumbs. Let's try to determine axis of this EKG. So if we look at lead 1, it is clearly positive. That QRS complex is, in fact, all positive. So that would be 1 thumb up. If we were to look at lead 2, the QRS complex is, in fact, isoelectric. Isoelectric means that the positive and negative portions of the QRS complex are about the same size. And so if we're thinking about what does that mean if lead 2 is isoelectric, the perpendicular, remember, the perpendicular angle to lead 2 is -30. So the axis for this particular EKG is probably right at -30. So this EKG probably has a little bit of borderline left axis deviation. Let's talk about the causes of left axis deviation and right axis deviation. For left axis deviation, the most common cause is a block in the left anterior fascicle. Remember that left bundle branch splits into the left anterior and the left posterior fascicles. And if you have a hemiblock in the left anterior fascicle, that can cause a left axis deviation. Inferior MIs can also cause a left axis deviation. There are some resources out there that may say that left ventricular hypertrophy is a cause of left axis deviation. Other resources will say that it's not. In general, left ventricular hypertrophy itself is not a cause of left axis deviation. Depending on a cause of left ventricular hypertrophy, think of infiltrative diseases, scar tissue formation that may cause a block in the left anterior fascicle. In that situation, it may cause left axis deviation. But left ventricular hypertrophy in and of itself would be a very rare cause of left axis deviation. For right axis deviation, there's a large number of things that could potentially cause it. So if we think about axis being the average direction of the electrical activity during ventricular depolarization, we think about the amount of electrical activity in any given direction is going to be dependent on the amount of myocardium present. So if you have developed significant right ventricular hypertrophy, you've got more myocardium that is sitting over on the right side of the heart, and that's going to be drawing the electrical activity in that direction. And so from that perspective, it makes sense that right ventricular hypertrophy will be a cause of right axis deviation. COPD is also a cause of right axis deviation. High lateral MIs, especially if you see an abnormal Q wave in lead 1, that could potentially be a cause of right axis deviation. And rarely left posterior fascicular hemiblock. We also know that right axis deviation can be seen with a right bundle branch block. So this is a way for me to illustrate my point in terms of left ventricular hypertrophy not being a cause in and of itself for left axis deviation, because we already know that the left ventricle is significantly larger than the right ventricle in terms of the amount of myocardium that's sitting there. And so if you have concentric left ventricular hypertrophy, you're really just building up more myocardium in an area where it was already big to begin with. And so you're not really going to change the direction of the vector, that axis of electrical activity. Compare this to what happens with right ventricular hypertrophy. Again, you are building up the right ventricle in an area where the myocardium is typically fairly small in amount. And now we're building that up and we are drawing more electrical activity in that direction. Okay, so we have talked about axis in detail. We're now going to move on to talk about intervals, normal versus abnormal, and the potential causes for those. We'll talk about ischemia and infarction and the criteria for that briefly, and oftentimes I include looking for evidence of ischemia and infarction at the same time that I'm doing intervals and morphology. And lastly, we'll talk about the criteria for right ventricular hypertrophy and left ventricular hypertrophy. We're going to go through most of this fairly quickly. I'll spend a little bit more time on bundle branch blocks, but for additional information after you get through the end of this workshop, we'll talk about ways that you can expand your knowledge near the end. Okay, so let's talk about intervals. As a reminder, the normal PR interval is 120 milliseconds to 200 milliseconds. So that's 3 small boxes to 5 small boxes on a 12-lead ECG. If you have a shortened PR interval, look to see whether or not you have a widened QRS. And if you do have a widened QRS, consider Wolff-Parkinson-White. Look for that delta wave. Other potential causes of a shortened PR interval is atrial ectopy. So if I have a premature atrial complex, I might expect to see my PR interval shortened. Junctional beats also would be a cause of a shortened PR interval. Prolonged PR intervals, that's when we start thinking about first degree AV nodal blocks. In a first degree AV nodal block, as a reminder, the R to R is constant, the PR interval is constant, and you still have that 1-to-1 P to QRS. In second degree AV nodal blocks, that R to R is going to vary because you're going to start dropping beats. With Mobitz type 1 Wenckebach, second degree AV nodal block, the PR intervals are going to vary. So the PR interval will progressively lengthen, and then eventually you'll have a dropped QRS. In Mobitz type 2 second degree AV nodal block, your PR interval remains constant. And it's also important to know that the PR interval in Mobitz type 2 is often normal. So you don't really see a prolonged PR interval, but you'll see the dropped QRSs. In third degree AV nodal block, your R to R intervals are going to remain constant because you have an escape rhythm, whether it's a junctional escape rhythm or a ventricular escape rhythm that's happening. Your PR intervals are going to vary because your P waves and your QRS complexes are completely dissociated. Remember, you're going to see P waves because the sinus node is going to continue to send out electrical impulses causing atrial depolarization, but you have a complete block at the AV node, and so you have a rescue rhythm that's happening either from the junction or from the ventricles. So just as an illustration of what I just mentioned, so if we look at the top, we have a shortened PR interval, meaning that our PR interval is less than 120 milliseconds. Consider Wolff-Parkinson-White. And there's an example there on the right where it shows the delta wave and the shortened PR interval. For prolonged PR intervals, but you continue to have a constant R to R and constant PR intervals, that is a first degree AV nodal block. Second degree AV nodal block Mobitz type 1 Wenckebach, that PR interval progressively lengthens, and then there's a dropped QRS, and then your PR interval goes back to the original interval and then progressively lengthens again in the same pattern. Second degree AV nodal block Mobitz type 2, that PR interval remains constant, but the R to R will vary because you are dropping QRS beats intermittently. Third degree AV nodal block, your P waves and your QRS complexes are not associated. They're completely dissociated, so therefore your PR intervals vary. The R to R remains constant because you are in a rescue rhythm. As we move toward the QRS interval, as a reminder, the normal QRS interval is less than 120 milliseconds or less than 3 small boxes on the EKG. So a prolonged QRS interval is 120 milliseconds or more. If you have a prolonged QRS, you either have abnormal conduction, meaning a bundle branch block or a nonspecific intraventricular conduction delay, or we have a ventricular beat, meaning that the impulse for the depolarization is coming from the ventricles as opposed to above the AV node. If you do in fact have P waves and they are associated with your QRS complexes, then we're looking away from the potential of it being a ventricular beat and looking more toward abnormal conduction. So if you have a shortened PR segment with a delta wave, as a reminder, look for Wolff, Parkinson, White. If not, then we either have a right bundle branch block, a left bundle branch block, or a nonspecific intraventricular conduction defect. So first step, prolonged QRS interval, ensure that it's not a ventricular beat. Make sure it's not a PVC, it's not VTach. If you know for sure that this is not a ventricular beat, then we're going to look in lead V1 to determine if there is a bundle branch block or a nonspecific intraventricular conduction delay. As we look in lead V1, if it were a right bundle branch block, basically in that situation we have delayed right ventricular depolarization. And what I would expect to see in lead V1, if this were in fact a right bundle branch block, would be what's called a terminating R wave. And so that means that this last portion of the QRS complex is positive. So, you could potentially have the situation that we see in this example where I have an R and then an R prime. Or we could have a QR or just an R. Remember, in every lead, R is the only portion of the QRS complex that is positive. Q and S are always negative. So in this example that we're seeing here, we have an R, an S, and an R prime wave. And that R prime is that terminating R wave. The last portion of the QRS complex is positive. You can see over here in a normal lead V1 with no prolonged QRS and no right bundle branch block that we do not have that terminating R wave. We have an R and we have an S, and then it moves into the ST segment and the T wave. Here I have another example. In this situation, it's just the Q and the R. Okay. So that is a right bundle branch block. Remember, you only have right bundle branch blocks. You would only be looking for a block if your QRS complex is prolonged. For a left bundle branch block, I'm again going to be looking in lead V1, and I would expect that the QRS complex in V1 is going to be predominantly negative. It could be a Q or it could be an S, but it's predominantly negative, and that is the case here. And then I'm going to take a look to see whether or not there are any leads that show notching in a tall R wave. So typically I might look in lead 1. You can see I've got big R waves in lead 1. I've got big R waves in lead V6. And I'm seeing some notching on the side of this peak. And there's some notching that I can see happening over here in lead 1 as well. There's some notching in that R wave. And that notching, along with the predominantly negative QRS complex in lead B1, confirms that I have a left bundle branch block. So let's compare these two. Again, this is only if you have a prolonged QRS, making you concerned that there is a conduction delay, that you would be looking for these characteristics. So you can see here on the left bundle branch block, I have a predominantly negative QRS complex. So I've got a tiny little R right here and a giant S right here. And then looking in lead V6 in this tall R wave, there is some notching present. Over on the right, looking at right bundle branch block, you can see in this example, there is an R, an S, and an R prime. And then that is that terminating R wave that confirms that this is a right bundle branch block. Okay. So moving on, when we start looking at the other things that we look at for intervals and morphology. So morphology of P waves, we have talked about that already when we talked about rhythm as well as rate in parts 1 and 2. We've discussed the PR interval, we've discussed the QRS interval. And as we move into the QT interval, that as a reminder from part 1, the QT interval is something that I always allow the computer to do for me rather than trying to calculate it myself, because it has to be corrected for heart rate, and that calculation is tedious. And so that is the one thing that I will allow the computer to do for me. Next up would be to evaluate the ST segments and look at the morphology of the T waves, as well as looking for U waves. I incorporate this into looking for evidence of ischemia and infarction because I'm going to be evaluating my ST segments. I'm going to be looking for any abnormalities in the T waves and moving forward from there. And so we're going to combine these aspects. So let's talk about the criteria for ischemia and infarction. You may have seen this schematic before about the evolution of an acute MI. Obviously, this is the evolution of an ST elevation MI, or a transmural myocardial infarction. And so the first changes that you might see on the EKG as you move from A to B would be an elevation of the T wave as it gets a little bit bigger than the normal T wave that you see in A. Moving on to C, that's when you start seeing the elevation of the ST segment. Moving on to D, we'll see the development of a pathologic Q wave. You'll see that the ST segment remains elevated, but the T wave begins to invert. Moving on, that Q wave remains. The ST segment goes back to normal, but the T wave remains inverted. And at the completion of the MI, your QRS complex, your ST segment, and your T wave go back to normal, but you continue to have a pathologic Q wave that remains. So what are pathologic Q waves? Because not all Q waves are pathological. Not every lead has a Q wave. So if you have a normal Q wave, you can see an example there on the left. It's quite tiny. It's not very prominent. But a pathologic Q wave tends to be considerably bigger. So any of these criteria are reasonable to consider a Q wave pathological. So is it greater than 40 milliseconds or 1 millimeter wide on the EKG? Is it greater than 2 millimeters deep? Is it greater than 25% of the depth of the QRS complex? And then any Q wave seen in leads V2 or V3 are considered abnormal. To be able to confirm whether or not someone has had an old ST elevation MI on an EKG, you also need to see pathologic Q waves on 2 contiguous leads from the same territory. So for example, the inferior leads are leads 2, 3, and AVF. If I saw pathologic Q waves in at least 2 of those leads, then I would be suspicious that that patient has had an inferior MI at some point in the past. When we look at the ST segment and T waves, remember peaked T waves are associated with hyperkalemia. Normal T waves are positive in all leads except leads 3, AVR, AVL, and V1. T waves that don't match that are considered a non-specific T wave abnormality unless there are other ST changes that are concerning for some other pathology. ST depression is always abnormal. It typically means ischemia or subendocardial injury. It could also mean reciprocal change in the setting of an ST elevation MI. So for example, if I had anterior ST elevation MI, I might see ST depression in the inferior leads that are reciprocal change. You could also see ST depression with digoxin, hypokalemia. If there is ST depression associated with hypokalemia, you might expect to see U waves present as well. You can see ST depression with right ventricular hypertrophy and with right bundle branch blocks. ST elevations don't always mean an acute MI. If they are diffuse across multiple leads for over the EKG in multiple coronary artery territories, you would be considering acute pericarditis. Left bundle branch block also will cause ST elevations. Left ventricular hypertrophy with a strain pattern will also cause ST elevations. Could be a normal variant. There's something called an early repolarization abnormality with J point elevation in the precordial leads. We typically see that in lead B2, B3. It could just be that normal variant. So there are examples of these on lifeinthefastlane.com. I would highly recommend that you take a look at that website to see what how many differences in morphology there are in the ST segment in T waves. It's a great resource, and going through all of those is beyond the scope of this particular workshop. So I would encourage you, after you get done going through this workshop, to move on to that website and take a look. All right, last up, we're going to talk about hypertrophy and the criteria for hypertrophy. For third year students, you should learn the criteria for left ventricular hypertrophy. Right ventricular hypertrophy is a little less required, but you should know how to identify left ventricular hypertrophy on an EKG. For more advanced learners, like fourth year students and residents, you should know the criteria for right ventricular hypertrophy. For left ventricular hypertrophy, there are multiple criteria that are out there. There are 2 very common ones that I use, and the patient could meet criteria for left ventricular hypertrophy if just one of these is true. Both of these do not have to be true, and so you need to know a couple of them, because if you only memorize one, you could be missing a left ventricular hypertrophy. So the first criterion would be if the R wave in lead AVL is greater than 11 millimeters tall. Remember, the R wave is the positive deflection in the QRS complex. If the R wave in lead AVL is greater than 11 millimeters tall. The other criterion that I use is to take a look in the precordial leads. And I look at the size of the S wave, the amplitude of the S wave from the baseline, and if it's significantly big, I will measure it. How many millimeters is that amplitude of that S wave in lead V1? And then I'll take a look at the R wave in either lead V5 or V6, whichever is bigger, and then measure the amplitude of that R wave. I will then take the size of the S wave and the size of the R wave and add them together. If they are greater than 35 millimeters, then the patient likely has left ventricular hypertrophy. These are those classic criteria that when you're looking at the precordial leads and you see these huge QRS complexes over the precordial leads that make you suspicious for left ventricular hypertrophy, kind of a classic presentation. For right ventricular hypertrophy, if the R wave is greater than the S wave in amplitude in lead V1 and that R wave is also greater than 5 millimeters, then you would expect that the patient has right ventricular hypertrophy. So that's it. This is the end of the workshop from the pre-work standpoint. And so your next steps are to review axis determination and common causes of axis deviation, review the causes of PR interval abnormalities, review how to identify bundle branch blocks on an EKG, review ST and T wave abnormalities and the indicators that are highlighting ischemia and infarction, review the criteria for evidence of hypertrophy, and then lastly, practice, practice, practice. Reading an EKG is a skill. It is a clinical skill, just like any other clinical skill that you have to practice in order to get better. You cannot cram this information before the exam and expect to do well. So if you don't practice and you don't use it, you will lose it. So good luck. And I hope to see the students who are watching this, I hope to see you in our face-to-face meeting where we're going to practice reading EKGs together. Thank you for taking the time to go through this workshop, and good luck.